Hey guys, welcome in. My name's Izzy. I am part of the marketing team at Caring Medical. Thank you guys for joining us today. We're going to get started here in just a few seconds. We want to make sure everybody can hear us. So, Mandy, can you check and make sure we're getting some hearing stuff? And no, I can't hear you. And then would like to introduce you to the man you've been waiting for, Dr. Hauser. He is here to present your cases, talk to you. We're going to be discussing those cases. We will let you know when it's your turn. Then we will make you a participant, and then you're going to come up, unmute your sound and your video, and then you should be able to talk. If we have any problems, we'll work them out as it's going. So anyway, here's Dr. Hauser.
Thank you, Izzy. Thank you, everybody, for coming on this live webinar podcast. I wanted to see if we could do a lot of cases from around the world because sometimes the solution is actually very simple. So we're gonna see a lot of different cases, hopefully over 20 cases in the next 2 hours. I always like to pray. I'm one of the doctors in the world that believes in prayer. And all of us, I think, need prayer. So, dear Father God, thank you for this time. I pray that everything that's done in the next 2 hours would help people. I pray that you'd help the computer systems to work well. I pray that people would get a lot of help. We pray that through the Holy Spirit, your healing power would be manifest in the lives of the people we'll talk to and the loved ones that maybe aren't participating but have health concerns. Thank you for Michaela, who was supposed to be the host. She had her baby yesterday for baby Eden. So we thank you that baby Eden and her are recovering well. We commit baby Eden to you and thank you for her. In Jesus' name I pray, amen. Now, anybody who wants to dive deep in regard to prolotherapy or ligamentous joint instability, please go to our website at caringmedical.com and you guys can start to look at the various chapters. So we have about 1/3 of the 25 chapters released of the book Ligamentous Joint Instability, the Missing Diagnosis. You guys can get those downloads for free and dive deep into all the different things that ligamentous joint instability causes. We have some exciting cases that we're going to get right to today. So Amanda, if I could see Amanda. So Amanda has symptoms of swallowing difficulty, gastroparesis, tachycardia. Then basically, I looked at Amanda's. That was the one that you just made.
Hold on a second.
Okay. Was this the slide that you just made? Yeah, that is the slide that you just made. Okay. So
You can keep going.
okay, so basically I looked at Amanda's neutral MRI and then her MRI and extension, and basically this disc protrusion here is much, much greater with extension. So Amanda has, and I think the level above too, so it was C2, C3, C4, C5, C6, so C5, C6. So she has severe instability at C5, C6. So when she extends her head, basically the disc protrusion indents in the spinal cord here. You can see it right there. And you can kind of see that she gets a cerebral spinal fluid block. So that could increase the brain pressure. And then pressure on the spinal cord can cause a lot of things. She could get pain down, well, basically I think it's pain down her left arm. She could have, her legs don't seem to work right. Like when she's upright, like the last patient I just saw today, same kind of thing. He gets up and it's almost like the legs are disconnected to the rest of the body. So the question is, like, in other words, she says that, they were going to give her a trial of spinal cord stimulator. I would say that obviously if she was here in Florida, I'd say no, get some prolotherapy. Basically, you need some prolotherapy or stabilization from like C3 to C7. There are surgeons that would do a fusion surgery from like C4 to C6. So, in other words, I still think that this condition can be significantly helped before resorting to, which is kind of like a treatment of last resort, which is a spinal cord stimulator that just can reduce the pain, but it doesn't do anything for this instability. So then she's saying that she's also going to get assessed for Eagle's neck syndrome. Like, in other words, does she have a blocked jugular vein on one side because of an elongated styloid? But I would say that the same symptoms from an elongated styloid could occur because of this cerebral spinal fluid block there. Should I just go to the next?
I have the next person ready.
Okay, so
go ahead and make
okay, so here's Andrea. Vertigo, swallowing difficulty, bad itching in the head, visual problems, dizziness. Now, right away, I'm thinking ringing in the ears often is jugular vein compression. Jugular vein compression could give the dizziness, the visual issues. Oh, hey, Andrea, how are you? Welcome.
Hi, Dr. Hauser. I'm good. How are you?
Thanks for letting us talk to you. Here, I just wanted to show you something. Can I show you something?
Yes.
Okay. So long story short, when someone's had a fusion surgery, so you had a fusion, what levels did they fuse?
They fused C7, and then from C2 to C6, I did not have a fusion. It was an experimental surgery where they put anchors and screws down my neck, so I still have mobility, but
Okay.
there was no fusion involved because I
Okay.
didn't want my neck totally fused. But before that, I had the decompression surgery within the same year for the Chiari malformation.
Here's what I did. What I wanted you to see is when we do it, where are you located?
In Florida, 3 hours from you in Deltona,
Okay, so not
Florida.
too bad. Well, I put this slide in because there's going to be some people from Europe and different places that'll watch this. I just wanted to show the various motions that we do with a digital motion X-ray. So you know as well as I do, someone like yourself, I mean, the best thing would be is just to get a thorough evaluation for instability. And if you had something from C2 to C7, it's likely you probably do have some upper cervical instability. Now, when you have upper cervical instability, you normally have like tension here or tenderness, or you have like you move your neck and you have clicking, popping, grinding.
Oh, yes, all the
Okay,
time.
okay.
People can be beside me and my neck will click so hard, they'll say, "What's wrong?" And I'll be like, "It's just my neck. I've did that for years, even before and after the surgery."
So anybody, yourself or anybody who's had like a procedure, especially a fusion, and you have continued symptoms or worsening symptoms, it's likely it's going to be instability above or below. But I want to make sure, do you have any questions for me? But I think you should obviously the number one thing is to get assessed for, basically instability. So, you have to get some kind of a motion scan. Obviously, if you have the ability to come down here and have me review your case, I'm happy to. But do you have any other
Okay.
questions?
So the MRIs, the last ones I had was 5 years ago, and of course they all blew me off. So the digital motion, as I've watched all your videos, I can relate to all of them. So the digital motion will show more extensively. Like I've had the flexion extension like numerous times.
Yeah.
I went to, all the x-rays you can think of. I've been x-rayed from head to toenails, just
Yeah, but
basically.
usually, it's not with motion. You need it with motion. Because unfortunately, that's the problem. People think, oh, they don't have instability. But you know as well as I do, I move my head, my neck doesn't go Rice Krispies, crack, crack, click, click. Like if you got crack, crack, click, click, and you're basically having all these symptoms, and this is likely vertebral artery kinking. That's vagus nerve, vagus nerve. A lot of these things are either vagus nerve or jugular vein. And anybody who wants to, again, learn a lot, I'd say watch some of the videos that I've done on jugular vein and vagus nerve, and then go type in Ross Hauser, internal jugular vein, frontiers of neurology, and you'll see like a scientific paper that the staff here we publish in Frontiers of Neurology that explains like all the different things that the jugular vein causes. But any other questions that I can answer?
Just one question I've been dying to ask you because I've been watching you for a really long time.
Watch.
I have a ministry called The Voice of Hope, and I would love to interview you sometime because you are such a
Yeah.
voice of hope to
Oh, happy
so
to.
many. Oh,
What's the
thank you.
website, or if somebody wants to go on that, what's your website, or how can we find that?
Well, I interview on
Okay.
YouTube, on Facebook. I have a podcast. I was on radio. So any platform
Just
you want
type
to
in
put me
Voice of Hope on YouTube and you'll pop up.
on. Okay, yeah, yeah.
Okay. Okay. So you'll contact Michaela, Izzy, and then I'll be happy to be on it. So thank you for
Okay,
sharing.
awesome.
Have a
Because
great.
I interview a lot of people with all different conditions, and they would love to hear you.
Okay. Thank
So
you. Have a
thank
great day.
you.
Thank you
You
so much.
too. God
Okay.
bless.
You too. Okay, so anybody out there who, if like say you're in Serbia or something and you don't have access to a digital motion x-ray, the normal scan you want then is you want to get flexion extension x-rays, or you want to get open mouth view. This is where you can see open mouth. So if you want to know if you have upper cervical instability, you have them take an x-ray when your mouth's open, and then when you're like that, and sometimes that can show the instability. So Jamie, how are you? Where are you located?
I'm in Oregon, Dr. Hauser. I'm
Oh,
your biggest
awesome.
fan.
Bend, or what city?
Oregon City.
Oh, awesome. Awesome. No, you got a lot of stuff going on here. I just want to, there's a couple interesting things with your case. Like basically, one of the ways that you can tell if you have intracranial hypertension or your brain pressure is up is pulsation. So you have venous pulsations, you can even have arterial pulsations, but normally they're venous pulsations. Like, in other words, even the eye ultimately drains in the internal jugular vein. So the eye is drained by the episcleral veins. So if you're somebody who, like, you're seeing some kind of pulsation, it's likely that you have intracranial hypertension. And just like the last patient, Andrea, visual disturbances are very, very common. Right now, we've written 3 papers on the eye, not how cervical instability causes eye symptoms. So those will get published soon. Severe headaches is we see a lot, and then brain fog. These all usually represent the jugular vein. Now, if you don't have access, like you can't come to Caring Medical, you can have your doctor order a CT venogram of the head and the neck, CT venogram of the head and the neck. They can do that at any healthcare center, University of Oregon or whatever. And then on the thing, you say, also with 3D reconstruction. So you want CT venogram of the head, CT venogram of the neck, and that will show whether you have the styloids blocking it, you have the atlas blocking it. You've heard me a million times, it's normally the atlas blocking it. And then basically what happens is you can get basically a type of trigeminal neuralgia. So classic neuralgia, classically, when you have like peripheral neuropathy, it normally is you get cold. Like we all know diabetics, right? Their feet often are cold. They're cold. So basically, the trigeminal nerve that innervates your face, your palate, your eyeballs. Like if somebody has some goofy thing in the eyeballs, like they got dry eye disease or scratchy eyes, or their eyeballs don't seem quite right, it's a kind of a type of trigeminal neuralgia. So in our office, the only cranial nerve that you can actually see is the optic nerve, the eye nerve, because you can do the ultrasound beam past that. So like we always see extra fluid around the cranial nerve number 2. So it would make sense. You probably have some trigeminal neuralgia kind of thing. And then basically, I did several videos a long time ago on weird sensations. So just know, like yesterday, I had a patient with the creepy insect thing and all that stuff. So any sort of weird sensations is normally that the back of the spinal cord, the posterior columns, is basically getting extra pressure. So when you have, I'm just going to show you this. So like, in other words, most people have instability like because they're looking down too much. Well, when you're looking down too much, the vertebrae go this way. That's called flexion instability. When you have flexion instability, the back of the spinal cord, that has a lot of pressure. Like when an insect or something, like you step on a rock, like you almost know it's a rock and you know it's an insect going on you. Well, that sensation is the back of the spinal cord. So those are common things that you have some type of instability, putting extra tension on the spinal cord. This isn't going. Okay. Can I answer any questions? Yeah, that's weird.
Oh yeah, I totally relate to everything that you've said. I've watched almost all of your videos.
Thank you for watching.
I recently had a 3D CT scan with a new upper cervical chiropractor that I'm seeing, and it turns out and you can, yeah, now you can see my X-ray.
I was just trying to click it, but it wasn't.
Yeah, it turns out that atlas is pushed forward on the right and the left, but it's pushed forward 4 millimeters after a really bad accident that I had. And but I'm now getting treatment for that, and some of my symptoms are getting a little bit better. But I have a feeling that I need your prolotherapy.
No, I guess what I'm just saying is, like, the curve's supposed to be like this, so you could see where you're way, way forward. So you always hear me talking about you got a forward atlas, you got a forward atlas. So I just have a feeling if you go crazy with getting your neck curve good, so why don't you every 2 months, like whoever's taking care of you there, just get a lateral x-ray every 2 months, make sure your computer is really, really high. It's probably got to be way higher than you think. And then at nighttime, if you want to do the internet, but I'm just telling you, Dr. Hauser about 2 weeks ago got a flip phone. So I'm actually in the process of getting over my cell phone addiction or internet addiction. So I think most of us, if we feel like our brain is under stress or our brain is tired or we have brain fog, we got to admit our brain is sick and we got to lower the amount of work the brain has to do. Most of the work your brain, Jamie, my brain does is it has to process visual stimulation. 80% of what your brain does isn't to run your body. 80% of it is it has to respond to every single thing you see. And the problem is we're all spending our free time when we should be getting our brain refreshed. We do what? We go shopping on the internet, right? And obviously I shop for yellow clothes, yellow pants, yellow shirts. But the thing is now, I might see 500 shirts, and every time we do that, our brain has to work. And then because you have blocked jugular veins, it's impossible not to have a blocked jugular vein at your atlas. It's just impossible when you have such a forward head curve. So my advice for anybody out there, you included, you might want to do what Dr. Hauser is doing and just say, I got an internet addiction. I got to do something to try to overcome. So I probably reduced my screen time. I'm probably at about 50%. I went through the whole withdrawal that first day, man. It was terrible. On the weekend, like I wanted to, obviously go on the internet, but I think you're going to do spectacular. Like I would, obviously get your neck curve good, go to the atlas person. And then at that point, if you're like, when I lay down, I feel great. When I'm upright, I don't feel so good. And then if you have clicking, popping, grinding, you're going to have to find somebody, whether it's me or somebody, to do upper cervical prolotherapy. But you should do great. Like you're exactly the kind of client that we see at Caring Medical. But any questions?
One of the things that has limited me, besides having previous doctors who couldn't get that atlas pushed back down where it was supposed to be because it was so high, now I feel like I'm making some progress. But there was also a problem that C4 was rotated really, really hard. So when I lay down, it's worse than if I'm standing up. So it's like for many years now, I haven't been able to get any good drainage.
Why don't you make sure, like, you might have a stylet, because people don't realize when they lay down, their chin goes, like when you lay down, it's normally that way. Just try to make sure when you lay down that your head is back, your chin's away from your neck. Okay, I got to go to the next.
All right. Thank you very
But
much.
thank you. Thanks for volunteering. Thank you so much.
Actually going to go back to the very first one, Amanda.
Okay.
So it's slide 3.
Okay.
I'm going to.
Okay, we're back to Amanda. Hey,
Hi.
Amanda.
Hi.
Did you hear what I had to say about your X-ray?
Yes.
Okay, so what I told Izzy to do was we're going to make a figure. Do I have your permission to make a figure based on your MRIs?
Yeah.
And then I'm going to send it to you because there's a drastic change in your MRI. In other words, when you're in the neutral position, when you're not extended, when you're in the neutral position, the disc protrusion here, it's not indenting in the spinal cord, but when you go back, it indents in the spinal cord. So that has the same effect as a blocked jugular vein because it's blocking your cerebral spinal fluid here. So that's
Okay.
with extension. So that's why somebody like yourself, when you do cervical curve correction, you might say, no, when the computer's up or I try to extend, I feel worse. Like you feel worse because your instability is actually with extension.
Okay.
So I'm just
Yeah,
letting you know,
I
like
actually get mood changes when I look up. So
yeah, no, that's exactly right. So your brain pressure for you, it's unusual in that it's going to happen with extension. So I'm just letting you know, you definitely have dynamic cervical instability that should respond to either prolotherapy or a cervical fusion. You know, like from like probably C4 to C6. I'm just surprised that they right away went to a spinal cord stimulator when you actually have documented instability.
that's what I was kind of wondering, though, what direction they were going with this. And I didn't feel right about the spinal cord stimulator. So I'm glad that you're helping direct me to that,
What
that's not the right
what's
way to go yet.
do you feel like you've been evaluated adequately after this MRI by a surgeon that does cervical fusions?
No.
Okay.
And now
Are
half
you
my
in?
throat
What
is
state are
closed.
you in?
Minnesota.
Okay. Why don't we just do this? I got to communicate with you with Izzy anyway because we got to communicate with you because we got really good images that I'll show you, and then what I'll do is if on the referral list we have some surgeons in Minnesota, I'll let you know, and
Okay.
then there is a prolotherapist in Ron Hansen in like in upper Minnesota. So I'll get you his name too. Okay.
Okay, great. Thank you.
Hey, great talking to you. Okay. Hey, Holly. Okay, so Holly, interesting with Holly, she has a lot of different diagnoses and also tethered cord. So I wanted to talk about tethered cord. So basically, tethered cord just means that usually it means the phylum terminale, the end of the spinal cord, is very, very tight and it's pulling the spinal cord down. So you have a lot of spinal cord tension. Now, normally, and we'll see with Holly, normally you would have pain down the legs. You might even have some bladder or bowel issues. So we'll talk to her about that. And then we need to know what symptoms, like what symptoms. Now, normally when you have neck pain, if it's related to instability, you don't normally just have neck pain. You normally have clicking with rotation of the neck, and often the head feels too heavy for the neck, and some people just call that bobblehead. Should I keep going?
Um,
There's no Holly.
no,
That's all right. I appreciate. I
Oh,
look
you
a bit
got
funny.
your prism glasses on. Show everybody your prism glasses so people. Okay, so you can get those on the internet from $20 to $150. So, oh, you got your neck collar on. You got your prism glasses.
I'm in a lot of pains. I've been poorly for quite some time, so I apologize. Apologize. I do look quite strange.
No,
And
Holly, do you have Ehlers-Danlos syndrome?
yes, I do. And
Okay.
how did you guess?
Yeah, well, I mean, I've been treating it for like 30 years, so usually I can tell. But okay, I want to answer whatever questions.
Oh, sorry. I was just saying the symptoms you described, I match those. So I get the clicking with the neck, and I feel like a bobblehead. And then with the tethered cord, I get the pain down my leg, and like weakness and numbness as well. So yeah, I kind of match it to a T.
Where are you at? What state or what country?
Oh, so I live in the UK.
Okay.
I've had some imaging done by a Spanish neurosurgeon called Dr. Giletti. And he did I think it was an upright CT scan and some MRIs and stuff. I've been advised to get a fusion and a tethered cord release, but I'm looking at other options because surgery is very expensive.
It's a great question. Okay, so let's just talk. Dr. Giletti has a very good reputation. Again, I have never spoken to him, but I've had patients that have seen him. So, was he nice? Did you like him?
Yes, he was very nice, very friendly, and I felt like he was one of the few doctors who'd ever really believed me and taken me seriously, because sadly LMS is not particularly known about in the UK, and you're often dismissed quite a lot because people assume it just means you're hypermobile, and that's just one of many symptoms.
Well, just as an interesting question, do you have cracking, clicking in your lower back or your pelvis? Does anything crack or click?
I do, yeah. I get it around I think it's my SI joint and my hip. But I'm not sure. When I
explain why I like to do prolotherapy in a patient like yourself versus right away doing surgery. But just know it's my opinion, The reason is, as well as I do, if we assessed you, you probably have 8 different body parts that are very, very unstable. Like they're very, very unstable. And the thing is, the goal is obviously to get you functioning so you're working, you have a beautiful life, everything's real nice, you know what I mean? And the problem is when a surgeon just stabilizes one thing and the person has a bunch of different instabilities, you can't get 8 different surgeries, right? Is she frozen? Is Holly still there?
She is still there, but she's frozen.
Okay, I'm sorry. I'm sorry that Holly's in UK, so she's frozen right now. It's
she's coming back.
Holly, can you hear me?
Yes, I can hear you now.
Okay, I'm sorry about that. I'm sorry. But no, long story short, obviously someone like yourself, normally we probably end up seeing somebody like yourself around 12 visits, I'd say. So that's the very hard part, because ultimately what as well as I do, you probably have instability here, you probably have instability in your thoracic, you have instability in your lower back, you have instability in your pelvis, you have instability possibly in your shoulders and your hips. So prolotherapy can deal with all of them. Yeah. Do you have? Yeah. Sorry that we're going in and out, but that's kind of the more instability you have, the more I like to use prolotherapy, because prolotherapy is injections that thicken and tighten the ligaments. And once a person with hypermobility EDS has one area stabilized by prolotherapy, it gives them a lot of confidence that the prolotherapy is going to resolve the rest of the instabilities. I definitely have people that I do prolotherapy in the upper cervical region and it doesn't tighten them enough and they need surgery. But I always feel like you should try conservative care before doing an upper cervical fusion. But Dr. Giletti has a very good reputation.
Okay, next one is
okay. Maybe just follow up with Holly, because I just want to make sure that I answered her questions. Okay, so Andrea,
let's skip that one for now.
Okay, we're skipping that one.
Stephanie.
Okay, we're going to okay. So Stephanie, very, very interesting case. So she has foreign accent syndrome. So it basically, when you talk, you all of a sudden get an accent.
Yeah, I'm from the West Coast. I grew up in San Francisco Bay Area. I'm in Portland now. August 2023, I woke up with a Southern accent. it's been the craziest thing. You know, everyone's like, are you faking it? I don't think anybody could fake an accent like this long term, but I've had a lot of neurological issues over the last couple of years and been pretty much dismissed by most of my neurologists. So it's pretty frustrating.
Steph, here, I just want to tell you a story of what happened yesterday. So the staff tells me, they tell me the patient's doing great. Their seizure disorder is way better. So I think I'm going to walk into the room and it's going to be amazing, right? So I walk into the room of the patient. They're on their third visit. Lovely girl, like 24 years old, redhead, really nice person. And I walk in there and I just assumed like there's going to be happiness and everything. She's on the table and she's like, eat what? Like all kinds of, like you think like a nutcase. She's having a full Tourette's episode, and then we get her in a certain neck position, and it totally goes away. And these sort of things, like, come on, could foreign accent syndrome, like in other words, somebody all of a sudden has an accent, and then Tourette's. Like, are you serious? It could be from the neck? Absolutely. So I just want to show you a couple things. So long story short, you know as well as I do, there's different speech centers that control your voice in the brain, right? So over the years, when you get a jugular vein block, so let's just say you got assessed and you definitely have intracranial hypertension because the jugular veins are blocked. Depending on which area of the brain, like you might have increased pressure in the part of the brain that controls the muscles of speech. That's called Broca's area. So when you have increased pressure in Broca's area, you can all of a sudden have an accent. You could all of a sudden say words that you didn't mean to say. And then the other thing too is, when you hear me talk a lot about the vagus nerve, well, right next to the vagus nerve is the glossopharyngeal nerve. And then there's other nerves that are in this area that control speech. But I'll bet you have, if you did the test, the non-invasive test, so the non-invasive test for intracranial hypertension is optic nerve sheath diameter. So that's an ultrasound in the back of the eye. It measures the optic nerve sheath. Then the other non-invasive test is called MCA velocities. It's a transcranial Doppler test, and the pulsatile index in you would be high. Obviously, it'd be interesting to look at your MRIs and just see, could I see any increased pressure in the parts of the brain that have to do with speech? But I think you're on the right road. Just go the road of well, let's just talk about your neck. Do you have clicking, popping in the neck, or you have any neck pain?
I do. I've been in some serious car accidents, but they keep telling me. And it's funny, I was listening to you earlier about head positioning. I've had stroke-like symptoms too. In both or most of my serious ones happened after I was painting a ceiling. And I told the neurologist that, and they totally dismissed it.
Yeah. So you might want to get, if you can come here, great, come here. If you can't come here, CT venogram of the head, neck, look at, you're probably going to have some significant jugular vein blocks. And I just have a feeling. So I'm just going to encourage you, just go down that road. I think just go down the road of, do I have a structural neck issue causing like a jugular vein block, and that's like screwing up my brain. Then I'm getting all these weird things. And always remember, a doctor's not going to, a normal neurologist isn't going to necessarily have a lot of experience with a person who now has a Southern accent. But I'm just saying, I've taken care of weird things over the years. So it's definitely something that absolutely could be from jugular vein compression. So
thank you very much.
Yeah,
It's nice to know that.
You're on the right road, definitely. Okay, should I go back?
You're up to, let's see, Dr. Roylene?
Which one? Oh,
yeah, right there.
Oh, hey, Doc. ACL. Oh, wow, something beside the neck.
Hold on one second. Okay.
It's a doctor?
Yep.
Yes.
Dr.
Can you hear me?
Roylene.
Hi, can you hear me?
Yeah, I can. I can't see you, but I'm sure you're very beautiful. Here, what I want to do is, I just see Danielle here. She's my associate. So I'm looking at the ultrasound screen. What she's doing is, she's putting stressors on the knee. And what you normally see when you have your kind of history is, we'll see the joint space. Like when we put a stressor on it, the joint space in this patient went from 4.2 to 7.6. So definitely do a stress test of the knee under ultrasound guidance. And you normally see like in this person, they had a 3 millimeter instability. And when you tighten that ligament with prolotherapy, the pain normally goes away.
Okay.
But that's kind of what I would do. And you know as well as I do, what happens is a doctor could do a perfect ACL reconstruction, but it's going to decay. Like, you know, it's going to decay. Like, it doesn't last forever. So you're like at the warranty. Like they probably warranted it for 20 years, and at the 21st year, so, but instead of having reconstruction again, I mean, I would just go the route of every 4 to 6 weeks, get prolotherapy. The thing about prolotherapy or PRP, and people say, well, what should I do? Get prolotherapy or PRP? No, PRP isn't a procedure. The PRP is just the substance that you're injecting with prolotherapy. The thing is, you got to have the doctor just make sure that they do all the ligaments. So in your particular case, I would do where the ACL is, I do the MCL, I do the LCL. And then, but you got to get it like every 4 to 6 weeks. And, let's be honest, but you're an active person, so it's probably going to take, 4, 5, 6 visits to get completely cured. I'm getting back to training. You probably know this. I've done 5 Ironmans. So what happened was I got a knee injury. So I've had 3 prolotherapies. So I'm back to jogging slowly. And I'm going to just see how my knee does after the 3. But what might happen is when I start running faster, it may start hurting. And then that's how you determine like how many prolos, then I'll get some more prolo. But long story short, when you get prolotherapy and you're exercising, the pain from the exercise should go away within 2 hours. Okay. If like say you get prolotherapy, PRP, it's feeling a little bit better, then and you want to do some exercise, always think about what exercise can I do where I'm stressing the knee but the least amount. Like in other words, race walking is less stress than jogging, and jogging is less stress than running. And then elliptical, if you don't move your feet when you're doing the elliptical, that's even less stress than race walking. But my athletes who want to get in shape, so race walking, when you do race walking, your knee's extended, and the knee's more stable when it's extended. That's why people could have knee problems like yourself and still do race walking and feel fine. So when you exercise, if the pain lasts longer than 2 hours after the exercise when you're getting prolotherapy, it means that you induced a little bit of instability, which of course you don't want to do after prolotherapy because it means that you stressed too much the ligaments that just got treated. You know what I mean? So you're trying to stress them a little bit. And the other thing too that you can do is when you have a ligament injury and you're getting joint swelling, right? That means the joint's moving too much, so the joint's producing too much fluid. So after prolotherapy, like when I jog or like I ride my bike to work, I live 5.4 miles from work. So when I ride my bike to work, when I get here, my knee that recently got prolotherapy should not be hotter than the other side. If it's hotter than the other side, you touch it, it means you induce some instability with the exercise. So the exercise is hurting your recovery after prolo, not helping the recovery. But I want to answer any questions. Do you have some questions?
Well, I had sent in my x-ray, which shows the joint instability because one of the surgeries, they took out half of the meniscus.
Yeah.
So I'm just curious, will I have to have, because I have some people looking at that x-ray and they're saying, oh, you're going to need to have joint replacement surgery, and prolotherapy or PRP might put it off for a period of time. But I'll be honest with you, I don't really have a lot of knee pain. I have some stiff.
No, resolve the instability. Once you resolve the instability, the decay of the knee, the degeneration of the knee is going to stop, in my opinion. I've been doing this for 33 years, and we have lots of horrible MRI looks and all that stuff. And once you resolve the instability, I mean, the people just don't have pain. And then they just do whatever you want to do. You want to bike, you want to hike, you want to run. The body's really good. Like if you're injuring something, you're going to have pain. So if you resolve the instability, yeah. No, I'm just saying, I just think the prognosis for you is very good.
Excellent. Thank you.
Rach, why don't you, any questions? We'll get to your case. Oh, is it your daughter, Hannah?
Yes.
Okay. Thank you for letting us look at your case. So, like the other patient who has hypermobility EDS, again, I have a bias. In 1995, I wrote the first thing on using prolotherapy for Ehlers-Danlos syndrome. So that was like 30 years ago. So obviously, I have lots of kids that I saw when they were 13. One of them's a PA now. I have another one that I saw that's 13, that both of those kids looked like they were going to need a wheelchair when they came in. And now the ones in China, she's fluent in Mandarin and she's in school there by herself. So just know, because this is just again my bias. When you have hypermobility EDS, most of the symptomatology that's disabling Hannah or anybody else with hypermobility EDS, it's from elongated ligaments. It's elongated ligaments. So the long story short of it, once Hannah gets one area treated, it could just be her knee, it could be her shoulder, and the family sees like the thing would sublux, she'd be in a lot of pain, and all of a sudden it stops subluxing. The family knows, geez, like we don't have to fear anymore because we could get whatever body part it is proload. So yeah, so just that's why I think most people with hypermobility EDS that have symptomatology, it's good to get under the care of a prolotherapist, especially an experienced prolotherapist, because half of the thing is this, all the anxiety of it. And then once you get instability of your neck, it's crazy, all the symptoms, right? So I want to make sure we answer whatever question you have. It's mostly related to her knees when her knees are bent.
Yes, that's right.
Okay, I'm gonna tell you what to do. Can you do this for me? And then let Izzy know. Okay, are you ready?
Yes, yeah.
Okay. So recently, Danielle had me consult on a case, hypermobility EDS, that was very much like Hannah, okay? And then Danielle wanted me to consult on the case because it seemed as though there wasn't a lot of instability, okay? So basically, all I did was the person was bent, right? And instead of poking on the tendon, I was on the side of the tendon. And then basically there's a condition called fat pad impingement syndrome. Fat pad impingement syndrome. So long story short, basically I had Danielle, she numbed the fat pad. So she just put numbing on in the fat pad and the person started crying like 15 minutes later because it was literally the first time that all of her pain in a long, long time had ever gone away completely. I wanted just to review the case so you guys could you could research fat pad impingement syndrome and then maybe do the same thing. Now, the treatment of fat pad impingement syndrome, assuming that Hannah doesn't have instability. So again, I would do what I had the other client do, Roylene, was to do some stressor maneuvers and just see if the knee's stable or unstable. But if it's stable, I would do the same thing. Like I'd look up fat pad impingement syndrome. Now the treatment is, believe it or not, Dr. Hauser is going to say something that he doesn't ever like to say, which is you either have to take out the fat pad, which is a surgical thing, or you have to inject it with steroids. I'm not a big steroid person, obviously, because I like regeneration. But long story short, I think what happens in some people is the fat pad, it gets caught between the two bones. That's why when she bends her knee, it's like crazy pain, or she walks and it's crazy pain because there's a lot of nerve endings in that fat pad.
Okay.
Fat pad impingement syndrome. That's what I think when I was reviewing the case, I would want her to get evaluated for. Just for fun, if you could let Izzy and Michaela know, like if you did that, like, like how did they find it or they didn't find it?
She's had an MRI and it ruled it out. So they didn't think she had that. They did check her for it, which is why her conditions kind of remained a bit of a mystery.
No, but I mean, but you can do the next thing because there's a lot of false negatives. So the next thing is, again, somebody could inject the fat pad, right? Just inject
Yeah.
the fat pad. Then, in other words, like there are times where, like the one patient, it said a occult tethered cord. Occult means the MRI did not show the tethered cord, but the person has all the signs and symptoms of it. You know what I mean? So the problem is doctors, especially surgeons, it's very hard for them to do a surgery when the MRI didn't show it. So you could understand the dichotomy. I'm just saying, because I'm not a surgeon, I can do other things. So I'm just saying it would be interesting under ultrasound. You just have the person, it's very easy to see, put some lidocaine there, da da da, wait 20 minutes, have her walk around. And if it's like, holy crap, I feel like fine, then you guys, maybe then that same doctor, and then you can go on Google, it tells you like what steroids to inject in there. Then you just do it and then just see how she does. And, the doctor may be open to it, just because it's an enigma. But I'd love to have you follow up, like just let me know how it goes. But that's what I thought she had, so
Okay, thank you.
okay, great. Thank you for
Thank you.
letting us evaluate her.
Okay, we're gonna go to slide, I think it's 23, the seal.
Oh, a seal. A seal. Okay. Yeah, interesting case. So long story short, remember I said that when you have blocked jugular veins, because the jugular veins drain the brain, basically when the brain pressure gets too high, depending on what part of the brain is affected, will give you various symptoms. The one person that we saw, it could be that it's affecting the speech center. So all of a sudden she's talking in a southern drawl, like she is, so she has foreign accent syndrome. Other people, if the pressure goes on the frontal lobe, the hippocampus, like it can actually give you cognitive decline. It can various parts of the brain that have to do with how you view the world. So disassociation, depersonalization, derealization makes you feel like you're not even in your own body. And non-epileptic seizures are when the brain pressure is high, usually in the temporal lobes. In the temporal lobes. Is it a Isil?
Yes,
And
Dr.
where are
Ross
you at?
Hauser. Can you hear me?
Yeah, good.
Uh, it's a
What,
big
uh,
pleasure
what,
to meet you.
Thank you so much. Thanks for volunteering. I'm sorry of what you're going through. Some of the most distressing patients that I've seen is, man, why don't you explain to people what it's like to have derealization, depersonalization? It's dissociation. It's got to be terrible, right?
Yes, with the deliriumatics, it is really life-threatening condition. It can be life-threatening condition because the reality between your brain and the environmental reality just connection drops out.
Yeah.
And it can be lead to life-threatening incidents, accidents, and lots of brain damage with prefrontal cortex lobe because the pressure goes up really well, especially
Yeah.
you always
Yeah.
say I really experienced in a very deep way, maybe one of the most heaviest patient that you can ever see. It was really terrible that I cannot put in the words. I can express it with the words. The most worst part of it, the cognitive decline, especially the prefrontal cortex damage. And I'm still struggling.
Where do you live at? Where do you live at?
I live in Turkey. Sorry for my English.
Perfect. No, it's okay. So like I said with the other patient, so please get a CT venogram of your head and of your neck. So have somebody order that.
Yeah, I had it. I
Okay.
had.
So why don't you do this then? So in other words, if you're okay with it, let me see it. So, I mean, we're not going to be able to do it right now, but let me see it. The CT venogram of your head. A lot of times, Isil, they do the CT venogram of the head, but they don't do the CT venogram of the neck.
I haven't the images right now, but there is a small picture of it that, as you mentioned in your videos, the jugular vein compression from the C1, and especially I have an Eagle syndrome too. I think,
Okay.
I'm
I'm just letting you know the prognosis is very good. Don't ever think the prognosis is bad. I know you feel bad and you feel like kind of helpless, but I'm just telling you the prognosis is very good. Just keep going the route of getting your jugular veins open. And then have you had the tests? Have you at least had x-rays, the open mouth x-rays to look for instability?
Unfortunately, there is no digital motion X-ray in Turkey, and there is no well educated medical practitioner about this condition. So I learned from your videos. There is no.
What I'm going to do is what I'll do is, okay. So long story short, so any doctor with X-ray, you can just get X-ray. So just get a full. It's called a C-spine X-ray series.
Yeah, I had lots of CT scans.
No, I'm just telling you, get this series because it can show the instability, okay? So you're just going to get a lateral x-ray. This is called the neutral position. Then you'll get it in the flex position. Then you'll get it in the extended position. Then you'll get an open mouth x-ray in the neutral position. Then you'll get with lateral flexion to the left, and then do an x-ray flexion to the through the mouth. And I'm always happy to review them if you want me to review them. So, but you just got to get the x-rays. Any is there chiropractors in Turkey?
Yes, but there is no like Atlas orthogonal machines. They all manipulate by manually. So
but they have x-ray machines, right?
Yeah, just X-ray, and there is no knowledge about this condition.
I'm gonna have you'll contact me. I'll get your contact info and I'll write out what x-rays you need to get. And then let's try to find you like a conservative kind of chiropractor that can do the x-rays. And then I'll review your CT venogram. You know what I mean? Like, let's just do that. We can do a lot of stuff through the internet, so just you're heading in the right way. So I just want to encourage you, just you're heading in the right way. The prognosis is very good. So don't believe for a second you can't get better. That's a lie. Okay. You can get a lot better.
I'm trying to be positive about, but especially I have to say this, I feel the slippage of my C1 or the occiput. I can feel it. It comes with very big cracking, popping, grinding noises, and it slides backwards or forwards, and my jaw especially out of alignment, and it drops up from my skull. There is a severe instability in my jaw and my
I have some contacts in Turkey, okay? So let me just, you'll communicate with Izzy and Michaela then. I'll try to use some of the contacts in Turkey to get you good care, okay? So just stay encouraged. It's a lie if you start believing that you're not going to get better. You can get a lot better. Like, in other words, if you were here, I would probably look you in the eye and tell you the prognosis is very good, okay? So it's likely the prognosis is very good. I just need to get a few more information. So like in other words, I'll give you an example. So long story short, there was 80 patients that we reviewed from 2022 to 2024 that had hypermobility EDS. And I told my statistician, I want you to, do the statistics on the test results. And the statistician said to me, which of the 93 symptoms do you want me to do the stats on? Like, I had no idea this group of loose jointed people had 93 different symptoms. And do you know, I said, well, why don't we do of the 80, the amount of symptoms that people had, 60 out of the 80 had. Do you know 60 out of the 80 people had 29 symptoms? So just know ligamentous cervical instability can cause all this stuff. So just, you have instability. So it's a matter of like how to get the instability resolved. But I have to go to the next patient. So we'll be in touch, okay?
Okay. Thank you so much, Dr. Ross Hauser.
Okay.
We're gonna go to Howard. Howard.
Okay, and then Isil had, diagnosed with hypermobility EDS. Isil said, and you hear me say it, all these things are very, very serious. They're very, very serious. But the problem is once the instability hits the neck, there's just a lot of different symptoms they can have. And Isil would tell you it's a progressive disorder. That's why it may be where you just have a little bit of neck pain, but if it's from instability, it's just like a cabinet door where one of the screws is loose. If you don't get a screwdriver and tighten that one screw, the other screw is going to get loose, and then before long, the whole hinge is loose. But you could see where, but I would just say once she gets stabilized, she's going to feel a lot better. Okay, great seeing you. And then the next one is, oh, hey, Howard, how are you? You doing
Doctor,
okay?
thank you so much for seeing me.
I just want to explain first why I think some hearing loss is from the neck. Okay, so long story short, when you get a blocked jugular vein, so we saw that x-ray of that one person where the x-ray wasn't like this, it was like this. So the first thing for Howard to do is just see, does he have a good neck curve or the neck curve is reversed? When the neck curve is reversed, it blocks the jugular vein. When it blocks the jugular vein, extra cerebral spinal fluid can go on the various cranial nerves. Well, one of the cranial nerves is the auditory nerve. It's also called the vestibulocochlear nerve, and that's how you hear. So you could see where if the fluid can't get out and it keeps going on the ear nerve, the auditory nerve, what eventually happens is the auditory nerve can get destroyed and you get hearing loss. Now, even if Howard, like what percentage hearing loss would you say you have?
They're calling it moderate, not requiring a hearing aid in the high frequencies, typical for noise or age-related hearing loss. And when I do the word discrimination, I get about a 96 out of 100.
Okay, so that's good. Well, you would want it not to get worse, right? Like you want to know, like, what can I do so at least it doesn't get worse.
Well, I'm more worried about the tinnitus is the more bothersome symptom.
Okay.
Much more bothersome.
Okay, so long story short, can I just show you this? I know this is Charles' case, but see how this person has this ultrasound here? Well, if you could get somebody to look at ultrasound of your jugular veins or get a CT venogram, you want to see, do you have obstruction? Like, is your tinnitus worse on one side than the other?
No, it's
Okay.
It's pretty equal. Just that sometimes I only have it in the left ear, and the right ear doesn't have it. But once I have both,
Okay.
they're equally bothersome.
Yeah. So.
And the right side is pulsatile.
Okay. Yeah. Actually, well, the last case I did before I came here, this is interesting. The person had a 90% blockage of their left jugular vein from the carotid artery. So they just had this carotid artery smashing in the jugular. So the jugular is like a conduit, and then you hear it. The jugular vein runs right next to where your hearing nerve is. It runs right next to it. And the jugular vein is supposed to be a low pressure system, like 10 to 20 millimeters of mercury. But if you have a big block here, like, if you have your atlas is way forward, so make sure like, do I have a curve or I don't have a curve? If you have your atlas is way forward, then all you have to do is just do all the stuff that I talk about in the videos or go online and just, how do I get my neck curve lordotic again? Like, how do I get my neck curve lordotic?
So, doctor,
Yeah.
I did have, it's called an X-ray cervical spine, AP lateral odontoid, and flexion and extension. They did read that, I don't know what any of this means, but they did interpret it that cervical lordosis is maintained, and they didn't see any signs of instability. I know it's not as good as the.
No, but why don't you send me it, and probably what it is you still here's what you probably have. Okay, So let's say this is here, I'll just get it really close. Okay, so let's say your curve is probably like this. So this is a good curve. You probably have lordosis, but your atlas is still forward. Like in other words, you still have the curve that way, but it's forward. And then long story short, like if my curve's like this, but the atlas is still forward, even if I have lordosis, it's still going to block the jugular veins there. And if you have a good doctor, you could say, hey, doc, could we please get a CT venogram of the head and the neck and see is there a block of the jugular vein at the atlas? If there's a block of the jugular vein at the atlas, then again, you have to get rid of the forward head, and the head's supposed to fit right on the atlas, not like in front of the atlas.
I did have a CT venogram, arteriogram. It was of the head mainly, and they were looking for, stenosis of the transverse something or other.
Okay.
They were looking and fistulas as a cause of pulsatile tinnitus. They also didn't see a
Did it go down
dehiscent.
into the neck? Did the scan go into the neck? Could you check?
I will check because I have a way of putting it into
Yeah,
my.
just do that. Communicate with my staff, Michaela, because I'm just telling you, I'll be able to show you where the arteries hit in the vein. And then it may be sometimes with the arteriograms, it shows the vein. If it doesn't show the vein, you have to get a venogram. Just telling you though, go down that route, and I think the answer will be there. But sometimes the radiologist, let me just look at it. I'll look at it for you.
This followed a chiropractic cervical over manipulation,
You're
as
right.
you described in your paper.
Yeah, I'm sorry.
About 3 days after.
I'm sorry. That happens. I'm sorry.
So is that prolotherapy?
Yeah. Yeah. Like obviously, well, let me ask you this. You do got clicking, popping, grinding in your neck or not really?
Lateral rotation to the left.
Okay. Yeah. I mean, you're probably going to need.
It's not the loudest.
Yeah, you're probably going to need a little bit of prolotherapy, and you're probably going to need, a little bit of curve correction. Just go down that route, and I'm happy to help. If you want me to review some of the scans, it would just be interesting because if you really have pulsatile tinnitus on one side, you and I should see the artery hitting the vein, so I could at least show you where the artery is hitting the vein.
I do have a carotid ultrasound scheduled for tomorrow.
Okay. You might want to ask them while they're there, could you please just see, I'm just telling you, it's usually at C4-5. Just tell them, hey, I was on this crazy podcast with a crazy doctor, and the crazy doctor said he just thinks the carotid artery is going to be hitting my jugular at C4-5, and just have them, and I think you'll be able to see it. You'll see it right on the ultrasound, I'm telling you.
Well, I'm not the sharpest pencil in the pencil case, but
Hey,
I don't consider you
Terry.
crazy. I consider you a prolific scientific writer, and I thank
so
you
much,
for all
bud.
you do to help people.
Thank you. Hey, man, I want to help you. Great seeing you. Thank you, Howard.
Pleasure's all mine.
You too.
We're
Thank
going
you.
to go back up to Karen. I think she's
Oh, Karen.
12 or 13 or 14.
Okay, Karen. Everybody loves Karen. Who doesn't like a Karen? Oh, strange sensation. She must have a strange sensation. Bladder sensations. She has mild POTS, no gag reflex. Okay, that's interesting. No gag reflex. Okay. Very spry, quite strong 65-year-old, struggling with health issues over a year, eats good exercise, really tries to do things that are very, very healthy, right? And she has a scoliosis, C5-6. Sometimes you don't have a surgical fusion, but you have a degenerative fusion. Now, because she has a degenerative fusion there, likely she probably has instability just above it. And then she has thoracic outlet. So the thoracic outlet is the space between the clavicle bone and the first rib. And the space is very narrowed by the hunched over posture. So when you have thoracic outlet, one of the easy treatments, if you will, if you don't have instability, is to hang. So if you've been diagnosed with thoracic outlet, and thoracic outlet, it means the artery can be blocked there, the vein, or the nerves that go into your arm. So I have cases where we correct the cervical curve, the stability is better with prolotherapy, but the person still has intracranial hypertension. So let's just say somebody had uh, head pressure on the left side here, and they've done the stuff that I've wanted them to do, the staff here wants them to do, and they're still not better. Sometimes the compression's right here. It's in the thoracic outlet. So the treatment is to do exercises that get your shoulder blades back, possibly to hang. Are you Karen?
Yes.
Hey, thanks for volunteering. I definitely want to answer all your questions. So you must have some very intriguing questions.
The
Now you
biggest
have internal buzzing or shaking. So I did make some videos. So I'd really recommend people watch the videos. I made a whole series on strange sensations that people had. So long story short, if somebody had a bee buzzing on their skin, or you had a vibration device or a massager and it was on your right leg, there's obviously a neural pathway that tells your brain that, hey, there's a buzzing sound or there's a buzzing sensation in my right leg. So what happens is when you have like a degenerative fusion or some kind of fusion at C5, 6, I'll bet you at C3, C4, C4, C5, you probably have a little bit of instability there. So when you have instability, it normally occurs with flexion, like you're looking down. So when the vertebrae move too much forward, it puts pressure on the back of the spinal cord. That's what gives the buzzing. So have you had like flexion x-rays, extension x-rays, or have you had a flexion MRI or an extension MRI?
They did the x-rays, yes.
You had flexion extension?
Yes.
Okay. Do you know what that showed? Did it show anything?
There's so many comments on all of my x-rays and my MRIs. It's like every vertebrae has a comment. There's
Okay.
bulging
Do you have
disc.
clicking, popping, grinding?
Definitely
Okay.
lots.
Have you ever had some prolotherapy or no?
I had shoulder prolotherapy years and years ago, but nothing in my neck. No.
Okay. Well, like just with this kind of a history, the C5, 6, with the internal buzzing, with the gastroparesis and all the stuff. I mean, I think you got to go the route of your neck, like you know as well as I do, and why you probably are watching my stuff is because you suspect you have, some kind of neck problem. So if you don't have an ideal curve, already work on your curve, and this is for everybody. Because when you do get prolotherapy, like if you already have a good curve, when you start prolotherapy, it's probable you're going to need less visits, So,
Okay.
and then when you're sleeping, so this is another thing which we haven't talked about yet, is most of the people get better, they feel better, and they get deeper sleep if they sleep in a position to have a good neck curve. So in other words, the problem is, most people's problems, right, is that here, I'll go right here, is the neck curve is reversed, right? Then you and other people, like we sleep in a position where the neck curve's bad. You know what I mean? So we all should be probably sleeping in a position where our head's extended, if you're able to. And then if you have right-sided symptoms, lay on the right side with your head extended. If you have left-sided symptoms, but do you have any questions? But I think if you go the route of curve correction and prolotherapy, I think you're going to do great.
I did have one question. I have this very strange, like the cartilage moves up and down, I think with the jugular vein pulse, because it's faster than my heartbeat.
Okay.
And every time I've seen 7 doctors and they just shrug their shoulders and go, I don't know. So I didn't know if you'd ever seen that before.
Yeah. Well, normally what I would do is obviously we have a really skilled ultrasonographer. So no, like you got to realize like the hyoid bone can actually press against like the carotid artery. Like I said, the carotid artery, it can like, in other words, you can imagine if somebody has, okay, So if we go like this, like here we go like this, right? That's a good neck curve. Well, imagine a person, everything is forward, right? See how everything's forward? We got to realize those bones are pushing stuff. It could be pushing your carotid artery. Now your carotid artery is literally hitting a bone. It's literally hitting a bone, and then you're feeling like it's hitting a bone, it's hitting a bone. So the test I normally order, besides just doing ultrasounds in the office, is CT venogram head, CT venogram of the neck. And what you're looking at on the CT scan, the venogram, is my carotid artery hitting anything? Because the pulsation thing is normally the carotid artery. The carotid artery is not supposed to be hitting your jugular. It's not supposed to be hitting the hyoid bone. You know what I mean? And if it's like, there's some people, the hyoid bone, instead, like in other words, the jugular, the carotid artery's over here, right? And the bone's here. Well, imagine your bone is shifted. Now it's touching, or it's on the carotid arteries now on the inside of it. Then every time, boom, 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 boom. So I'm just telling you that's normally what it is.
Yeah, because my neck is actually shifted off to the right a little bit because
Oh,
of the
exactly. Yeah, exactly. So your whole anatomy may be screwed up. So the treatment of it is you can yourself or somebody else manipulate the hyoid bone. So there's chiropractors that do that, or you got to change your neck structure.
Uh-huh.
Yep.
Okay. Oh,
Hey,
well,
thank you. Great, interesting case. Really interesting.
Thank
Okay,
you.
it is
We're gonna go to Charles.
Charles. Thank you, Charles. Oh, Charles. Oh, wow, look at that. Oh, okay, gotcha. Charles, okay. Um, Always been extremely active. He had a severe accident. So my neck was twisted violently to the left. Okay, so long story short, the thing is, we all know chiropractic manipulation helps a lot of people, but let's be honest, like sometimes, it may be that whether it's with jujitsu or it's an accident or it's a chiropractor who does too forceful of manipulation, a person can be left with ligamentous cervical instability. And this person had cracking, snapping of the neck. He had symptoms almost immediately. Gets tachycardia 2 to 4 times a month. When you have cervical destructure or breakdown of the cervical curve or ligamentous cervical instability, it can affect the functioning of the vagus nerve. So this is like some of the tests we do for the vagus nerve. So you can see where we're doing ultrasound in the lower neck, ultrasound in the middle of the neck, and then ultrasound in the upper neck. You can't even see it. So in this particular person, because you can't see the vagus nerve in the upper neck, it just means, man, that thing's getting annihilated there. This is what instability looks like when you do an open mouth X-ray with lateral flexion. So see right here, basically the vertebrae, the C1, C2 facet joint, when the person tilts their head, it goes like this. Like now there's a little bit of instability. And then in the office, what we're trying to do is we're trying to find out what structural dynamic internal jugular vein compression or vagus nerve compression is there. Like, is it from upper cervical instability? Is it from lower cervical instability? Is it from the cervical curve now is all reversed? Is it from an elongated styloid? Is it from the jaw? Is it from the forward head? We saw that one patient was from the forward head. And even if somebody has excessive kyphosis, that can also affect the venous flow.
Dr. is on there.
Okay.
No, just kidding. He's off now.
Charles, but anyway, that kind of explained all the things with Charles. So I think Charles has to go the route of looking at, basically, does he have some kind of compression of the jugular vein or vagus? And it's probable it's either from ligamentous cervical instability or that there's a breakdown of the cervical curve. Okay, the next. Is it forward or?
It should be right after Charles.
Oh, okay. Sher. Okay, so Sher, basically she has a neurologist. She has a lot of symptoms. She did have a fusion. Basically, here, long story short, so when you have a cervical fusion, now most of the time, fortunately or unfortunately, the people get cervical fusions before they've had a digital motion x-ray. So I think what happens sometimes is the surgeon fuses the main area of instability, but if the person would have had a digital motion x-ray, there probably was more areas of instability than just where the fusion was, right? So let's say Sher had C2, C3, C3, C4, C4, C5, C5, C6 instability, and then she gets a fusion at C4, 5. Well, guess what's going to happen, after the cervical collar comes off, after the fusion? Well, all of a sudden she's moving, right? She's still going to look down at her cell phone, even though she shouldn't. So she looks down at her cell phone, and because C4-5 can't move, there's going to be extra movement at C5, C6, C3, C4, C2, C3. And if she had instability before the fusion in those areas, though she didn't know it, well, those instabilities are going to be exacerbated. And that's one of the explanation of why you end up with sometimes more symptoms 2 months after a fusion, 6 months after a fusion, a year after a fusion. Now, because she also has other things going on, like a slap tear in her shoulder and some other things, it's likely she has some kind of overall ligament laxity. So the two most common types of ligament laxities that we see is hypermobility EDS, and the second one is called hypermobility spectrum disorder. So it just means that the person has long, lanky ligaments, and the ligaments need to be thickened and tightened, and the treatment that we do to thicken and tighten ligaments is prolotherapy. Is she on the line or?
Yeah, I'm here.
Oh, hey, Sher. Yeah, I want to
Hi.
answer any questions you have.
Yeah, I guess one thing is I've tried to get a motion radiology, some kind of a motion scan other than just the flexion extension.
Yeah, where are you at? What city?
I'm in Northern California. I'm near Sacramento.
Okay. Okay, near Sacramento. Okay.
Yeah.
Have you looked up on Google like digital motion X-ray in California? Is there any place or no?
I haven't had any luck of finding anything.
You're pretty far from Washington, right?
Yeah.
Okay.
It
Okay.
is. So yeah.
Oh,
So
can I ask you this? Can I ask? Well, you have had flexion extension X-rays, right?
Correct.
And they were read as normal, huh?
No. There was the instability was found
Okay.
there. Yeah,
Okay.
and that's basically what helped the neurosurgeon to piece everything together.
So I
To
guess
see
what I'm
that
saying was there
motion.
other areas of instability, not just that area.
They just haven't gone into it. It seems like my surgeon was
Okay.
just,
Why don't you
very
do this
commending.
just for fun? Because obviously you're volunteering here, so I want to help you.
Thank you.
Make sure I get your X-ray so I could look at them, and if there are other instabilities, I'll just let you know.
Okay.
Then you get some prolotherapy. Have you tried any prolotherapy or not?
I have not. I have not had an opportunity to do that. But I also seem to be suffering from maybe jugular syndrome or Foramen syndrome, because it's all my cranial nerves. I have so many different cranial neuralgias, and that's what I'll get a clicking and a popping up right into the left lower lobe of the skull, right there by the and anyway, that seems to be my biggest factor right now that is incapacitating me. Besides the exaggerated kyphosis, I feel like along with the tear in the shoulder, both of those are related. I have a clicking and popping that happens in the shoulder, and I could feel the movement at the level of the kyphosis. It like pops off, like moves substantially.
Yeah.
And I
Sure.
haven't been able to prove that on any kind of
Yeah.
imaging.
Has anyone, have you been checked for hypermobility, Ehlers-Danlos syndrome? Have you been checked for that?
Well, I just recently saw the rheumatologist, and she did not think that I had any kind of connective tissue disorders or autoimmunes in that way, but I do have
Do me
the
a favor.
Hashimoto's.
Go on the internet and look up Beighton scale and tell me, based on your own exam of yourself, what your Beighton scale is. So I would do that. And two is, like, it seems like you have well, let me ask you this. When you were younger, did you seem like you were hyper flexible or not?
Maybe a little bit.
Okay.
Yeah.
Yeah, so you probably have hypermobility spectrum disorder. And long story short, have you had an open mouth view, where you do lateral flexion?
I don't think I've done that.
Okay, so whoever did your flexion extension x-rays, have them do open mouth view where you bend to the side, and that might show the upper cervical instability. But I'm just going to encourage you, you're going down the right road, because like, it's not right, like something's still unstable. You had the fusion, but I have a feeling you have other instabilities and because you have multiple joints of instability, research some about prolotherapy, watch some videos, but it seems like you're a very, very good prolotherapy candidate. What we all can do, though, is we all can make sure we're eating right, try to get, the right weight, get our computers up, stop looking at cell phones, try to reduce our screen time. Like I told you, I've reduced my screen time probably about 50%. My brain's already feeling better, right? Like I'm already feeling like more like myself and not like stressed out, or I got brain fog that's terrible, right? Anybody who has brain fog that's terrible, your brain needs a rest. So the way you rest your brain is reduce the amount of visual stimulus, because every visual stimulus, the brain has to work to figure out what to do with it. Even as you guys are watching me, right? Your brain's like, what do I do with this? Like, this guy's a
That makes sense. And just on that note, that I did also get diagnosed with the intracranial hypertension, and then that turned into, they did a spinal tap, and then I went into CSF leak and
I'm
have
sorry.
several blood patches.
I'm sorry. How high was your brain pressure?
No, actually, at the point that they tested it, it was only at about 21,
I
but
know, but it's still.
I had gone down substantially by
I
that
got
time.
you. I got you.
Yeah.
Let's agree you're going down the right road.
Okay.
I know it's very discouraging right now, and you had a lot of stuff, but you're getting closer and closer to what the real problem is.
Yes, it feels that way.
You're getting it. So thank you so much for sharing your case.
Thank you. Thank you for your help.
Okay, we're going to Kathy.
Oh, is she forward or back?
After victory.
Okay, so here's Kat.
After he's.
I got it. Okay, so constant tinnitus, that's normally the jugular veins. Okay, widespread pain and stiffness. So we see in our patient population, when you have widespread stiffness all over, it normally is either there's a vagus nerve issue or in the body, or there's a lot of cervical spinal cord tension. So normally people like Kathy have had MRIs, and remember that one MRI I showed where the disc protrusion was hitting the spinal cord? Well, you got to realize, like, that disc protrusion could affect, pain throughout the body. Now she has probably dry eye syndrome. She has insomnia, memory problems. These symptoms are often due to jugular vein compression, the heart arrhythmias, and like, if you guys were with me about an hour and a half ago, you would see a person that is in and out of atrial fibrillation. So I've seen in my own office, he's in atrial fibrillation, he's out of atrial fibrillation, and he has severe vagus nerve degeneration. And then basically the latest thing with him was he has a lot of blockage of his left internal jugular vein at the level of C6, because I just sent him for a scan, but I couldn't look at the images. So we'll look at the images and just see what's blocking his jugular vein there, and that may be the key to like why he's flipping in and out of atrial fibrillation. And then she has, see where it says pain in the left chest. So if you have kind of like slipping rib, like you can be in bed and you're moving up and down or you're contracting your abs and you feel a clicking sound, that means you have ligamentous costochondral instability. So prolotherapy works good for that. There is a thing called cervical angina. I've definitely seen it. I probably see a case or two a year of cervical angina. Like there's even people that go to the ER, they think they're having a heart attack. Well, basically, when you have a pinched nerve, so you have a pinched nerve in the neck, and normally pinched nerves are dynamic, meaning that a person looks forward and the space of the nerve is like this, but when they look back or they go to the side, the space narrows and then they get a pinched nerve. Well, if the pinched nerve is on the left side, it can then feel like you're having a heart attack, like you literally have chest pain. You might even get short of breath. And when you have slipping rib, you get short of breath too. So getting an assessment by a prolotherapist is a good idea. Is Kathy here?
She can hear you. Yeah.
Oh, Kath, do you have any questions?
Yes. I was curious. I had asked, and I don't know why you can't see me. I don't know what I need to do to change that. Anyway, I had asked my chiropractor here. We live in a very rural area. I'd asked him about healing ligaments, and he said to heal the adrenal glands. And I'm like, okay. And I'm seeing a nutritionist, sort of, kind of. She's an old friend of mine, but she is trying to help me heal my adrenals.
Okay. No, those are good questions. Like here, long story short, you know how you hear me say a lot about the vagus nerve? I don't talk that much about the adrenal glands. I used to do all that stuff. I would prescribe orthomolecular products, and I still take orthomolecular products. Like they have a good product for the adrenal gland. And then when I talk about a pro vagus lifestyle, meaning like taking walks, try to decrease your visual input. Like there's just stressful things on the internet. We gotta, like in our free time, we just shouldn't be inducing stress to ourselves by the average person in America. They watch stressful things on TV, they watch stressful things on the internet, and these stressful things, or if you have a healthcare problem, like you've had healthcare issues for many years, this puts a great stress on your body. So then the adrenal gland has to do more. The vagus nerve has to do more because those things respond to stress, like they're trying to get you out of the stress. So then you get what's called adrenal fatigue. I've had adrenal fatigue. If you truly have adrenal fatigue, I'm just letting you know there are times where you got to get on a little bit of cortisol. So if there's an interesting book called The Safe Uses of Cortisol. So, and you might say, well, why would I want to get on cortisol? Isn't that a steroid? Well, your body makes steroids in response to stress, right? So if you got on, let's say, 15 milligrams of cortisol, you get on 10 milligrams in the morning, maybe 5 milligrams early afternoon, and you're like, oh my gosh, I feel like great. Like I feel great. That helps you know you really do have adrenal fatigue, and then basically because you're taking 15 milligrams of cortisol, the average day, depending on what's going on in your life, your body might make 50 milligrams. So if you're taking 15, you're still letting your body make the 35. But what I'm saying, what my feeling is, the biggest cause of human disease that's not related to diet, that's not related to infection, that's not related to genetics, it's a breakdown of the neck curve. And I just think breakdown of the neck curve, if you have vagus nerve degeneration, that's going to cause your adrenal gland to do even more. So you know what I mean? That's why I think everybody's got to work on their structure, reduce your visual input, reduce your screen time, make sure your computer's up, try to if you had, like, I'll give you an example. If you said to me, I'm just telling you, man, it just seems like I have more ear fullness on the right. Maybe I have a little bit more ringing of the ear on the right. Then maybe just try to lay on your right side with your neck extended. Like maybe do that 5 minutes every hour for like 2 weeks. Then try to sleep on your right side. And if you all of a sudden within 2 weeks start feeling better, that's another good sign that that position is helping your jugular veins open. So basically, the problem does relate to your neck. You know, if all you do is like lay on one side. So, so in other words, like anything that gets you healthy is going to help. I'm just saying, like, to try to get people well, it just seems like you got to get involved in the neck, you know?
Right, right, yeah.
Any other questions I could help you with?
So when I lay on my right side, I can feel my heart beating, and I'm like, is that normal? Is
No,
this like
no. I mean, obviously, I would test you, like I would test you in the office. But have you when you sleep on your left side? How how is that?
it's okay. That's why I sleep most of the night. I do try to get on my right side for a little while, and I don't know that
I'll give you an example how it gets complicated. So, okay. So, long story short, when you lay on your right side, it sounds like your carotid arteries hitting your jugular, then you hear your heart beating, right? Well,
right.
let's just say, for argument's sake, let's say your right jugular vein is 3 times the size of your left, right? So, for you to feel good, I'm going to have you lay on your right side, but the carotid artery is getting pushed into your jugular, right? So then we have to figure out why is that and how to get the carotid artery away from there, which usually is just improving your neck curve. So maybe, well, let me ask you this. Do you feel like you have more symptoms on one side than the other? Like, do you have more neck pain on one side or ear fullness or ringing?
I think so on my right side. Yeah.
Okay. So you can understand the problem because you're sleeping on the left side and it may be you have to sleep on the right side. Uh, so why don't you like work on your neck curve, try to get a good lordotic curve, and maybe during the day, even though you hear the thing, maybe you could just try laying on your right side at least during the day, like 5 minutes every hour. And just over 2 weeks, just see if you start feeling better. And if you do, we got to figure out a way to get you to sleep on your right side.
Right, right. Okay, well, I thank you very much for all
Yeah.
of your
Great
information, all your
seeing you.
videos.
Thank you,
And
Kat.
I'm getting a flip phone.
Thank you. Thank you.
Thank you.
Okay, well, next.
Next we have Katherine.
Okay, so Katherine, here, this is really interesting, right? Blackouts. So we'll talk to her about the blackouts. When you're stuck in fight or flight, let's just talk for a second. I recently had a Hollywood stunt person. So recently I had a Hollywood stunt person who's getting better with the prolotherapy. You're going to understand when you're a stunt person, your neck's getting grabbed and you're in all these fights and everything. So long story short, she was stuck in fight or flight. So I recommended to her to get a stellate ganglion block. So get a stellate ganglion block. So I actually had her, back in where she lives to get a stellate ganglion block, and she's doing really, really good. So basically, when you're stuck in fight or flight, it just means that your sympathetic system is way stronger than your parasympathetic. And obviously, the way I treat that is to get people's vagus nerves back to normal. But in this particular case, sometimes for some reason it just doesn't shut off. So one of the treatments that's getting more and more press is a stellate ganglion block, and anybody here can get that by any anesthesiologist. Katherine, so I want to make sure that I answer any questions you have.
Hi. Okay, so my biggest question, inflammation wise, I've seen so many different specialists trying to kind of figure things out with EDS, mast cell, POTS, all that good stuff. And I had someone do my genetics, and they pretty much told me, your inflammation is all messed up, your on and off switches are messed up. And so they were very hesitant to recommend Prolo for me because they said it stimulates inflammation. You're gonna your mast cell is going to go out of control, and you need to get it under control before you could even consider. I wanted to ask your opinion on that because my mast cell won't get under control. We've tried so much to make that happen.
No, it's a great question. That's a great question. So, long story short, like back early in the days in the 90s, and I've been doing this for 33 years, and it's pretty much full time. I've been doing it full time for 33 years. I probably have done procedure wise well over 100,000 procedures, like in the 33 years. Like I'm a very high volume thing. So if I say something, it's authoritative. I mean, like a doctor who does something 100,000 times, and the average person probably gets, in my career, probably let's say 100 shots or whatever, so anyway, it's millions of shots. Let's just say that it's millions and millions of shots. So basically, I had one patient one time in the 33 years. So this is about 6 or 7 years ago. It's a patient where we had the nurse anesthetist there. It's a complicated EDS case. Boom, 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 boom. There was one patient, one time I'm injecting them, and then they got the rashes and the da-da-da. So, so in that one case, I believe that I induced at the time, one time, I induced mast cell reaction. But I'm just telling you, in the other however many cases I've done, and I see a lot of patients with mast cell, and I'm not saying that cervical instability and cervical vagopathy is the only thing related to mast cell, but you understand if somebody's having inflammatory issues in the body, I'm thinking like, well, why? And most of the people that see me, and you're probably the same, Katherine, you've done diet, you're trying to reduce your stress, you're a lovely person, you're working on yourself, you're doing everything you can. You and I got to think the doctors are still missing something. They're still missing something. I'm just saying, I do all these videos in large measure so you can make a good decision. Like in other words, has anybody actually measured your vagus nerves? Has anybody actually done the right test that they should do for cervical instability? Has anybody taken seriously that you may or may not have a jugular vein compression? So in other words, like some people can't come to Florida. Obviously I'd love you to come to Florida, but if you can't come to Florida, you got to get a CT venogram, probably neck and there, because the thing is why I do so much stuff with the jugular vein, because darn well the jugular vein is a tube. The vagus nerve is a solid object. So in other words, if you want to see is something getting compressed in the neck, it's much, much easier to compress the tube, right? So that's why if you have jugular vein compression, darn well your vagus nerve's getting annihilated. And if your vagus nerve's getting annihilated, that easily could be the reason why, you're having anxiety, you're having fight or flight. And then as well as I do, if you turn your head, so I love history like you gave, like you said, lost peripheral vision and ability to look to the left. You know what I mean? So in other words, like there's something about this position, right? You're saying there's something about this position that I have a change. Well, that means the vascular system or the neurologic system for you is different when you're looking straight and you're this way. So there's got to be a bone that's moving in a way that it wasn't designed to be. So when we talk about ligamentous cervical instability, we're just saying that there's some ligament damage. The ligaments hold the bones together. And then when you do a certain motion, the bone's moving in a manner that God never intended it. So it's probably going to hit something or block something. So the reason why sometimes you need prolotherapy is you got to get the ligament repaired. But if you don't want to start there, at least get your curve corrected, build up your neck muscles, and then get the test, like get a CT venogram or get a digital motion X-ray. Or if you have to, you got to see the goofy guy in Florida.
Yes, I've been recommended to see the guy in Florida by multiple people.
Any other questions, though? I appreciate you letting us,
Yes, yes, sir. I do have one more. I'm fused from T3 to L4.
Okay.
So a very, very large fusion. And I still am swollen at the top of my rod. It's been about 5, 6 years. And even if it is touched, I can't wear any kind of halter top, anything, necklaces that are heavy. I go into SVT, cardiac episodes. And so I'm wondering if I were to get prolotherapy, would it be safe to mess with? I feel like I'm almost worse because of the surgery. Like it just put too much
Okay.
stress on my neck.
Well, you know as well as I do, I said it a million times, and you know what I'm going to say. There's likely right above, like C1, C2, C2, C3, C6, C7, there probably is instability. So beside digital motion X-ray, we have a Konica motion X-ray machine, which is very, very interesting. So long story short, I could literally have somebody dancing and we could see all the movement of the bones basically. So we have the capacity to look at any kind of instability, not just the neck. So you know as well as I do, you probably have pretty severe like nerve irritation there. So it's like it's crazy, like the thing's on fire. So when the thing's on fire, one thing you can do obviously locally there, you can get, steroid shots right there. But how we normally do it is you would normally get prolotherapy there, and you would normally we may want to inject a little bit of PRP where the nerve is. And if you were really, really concerned, I mean, we obviously, if you were really concerned, like I take people's viewpoints very seriously. Like I always say, as much as Dr. Hauser may test Katherine, Katherine's going to know Katherine's body the best. Like it's not going to be me, right? So if you said to me, like, I'm just very worried about, mast cell activation after prolotherapy. So, like obviously if you were here an extra day, we could just do a very little area at first. And, we could have you do more antihistamines, or I could give you a Benadryl shot when you're here, as a sedative, before the procedure. So we have ways, so I'm just letting you know, like I take what you say very seriously, and no panic attacks. I've had panic attacks, so I know, I trust me, I know what it's like. I've been in the water, thinking I'm going to drown, having panic attacks and stuff. So all these things can be from the jugular vein, because your brain's just not working right. So the brain is under so much stress. Because when your brain pressure gets high, the brain is 24/7 under stress because of the brain pressure. So then, of course, you feel stress and you're like, why am I feeling so much stress? So once the jugular veins get open, and the good and bad and ugly of prolotherapy and cervical curve correction is it slowly gets you better typically. So that's like the good, it slowly gets you better, but it's also the bad, it slowly gets you better. That's why when people come here, I normally can tell them how many visits, how long it's going to be. Like I recently had a really, really severe case, and I just was honest with her. I said, the whole process is probably going to take 2 years. It's not going to take you 2 years to start feeling better. But I mean, when it's all said and done, but that's kind of good when you have a doctor who's been doing it for 33 years, And then, I have a big staff, so it's not like when you come here, we have 2 buildings, we probably have 25 staff. It's, as you probably already know, it's a lot of people. And then I couldn't do even just this webinar unless we had the graphics. I have a big staff that can get your history, but hey, thanks. I just want to encourage you. You're on the right road. Instability, I know it's been a long road. And the other thing too is all of us have had SHIT that's been in our past, right? Like, if I told you all the SHIT that happened to me, you'd be like, oh my gosh, like I didn't realize Doc had it. There's just, even now, there's kind of some SHIT going on. And it's like, you and I got to just be looking, what do I need to do today? How can I help myself today? How maybe can I help my mom or my friend? And then if we just keep walking forward, we're going to get to the finish line. So you can't do anything about the SHIT. I should have had the fusion. I shouldn't have had the fusion. There's nothing you can do. All you can do is like, okay, this is the situation. I got to get the levels above it stabilized. So, and then, obviously if you can't come out here, but there's a prolotherapist locally there. I mean, you could, if they have a good reputation, but sometimes you got to see the goofball guy in Florida, but hey, thanks so much for sharing your story.
Thank you so much.
is.
We're going to go back to Victor. I believe it's around slide 30.
Okay, so Victor, we love Victor. Diagnosed with chronic tension headaches. The reason why I wanted to see this was one can understand if you have jugular vein compression and it's there all the time, the person can just feel like my head is in a vice all the time. So why don't you describe your situation, Victor?
Hi, doctor. So it's just more like the muscles, like the head is like tilted to one side.
Okay.
Yeah, so I have like a jaw, like the jaw is like moving out of position.
Okay.
Yeah, it's kind of like hard to talk properly because of like the muscles are like stiff and tense and things like that.
And
Um,
and massage and everything else, it never gets it to go away, really,
no,
right?
no. He
Do you have
actually,
clicking, popping, grinding?
yeah, a lot. So sitting down is very uncomfortable. Standing is uncomfortable. Lying down is uncomfortable. Yeah, just a lot going on. Just a lot
Where
going
are
on.
you located?
Canada.
Okay, so in Canada. Okay.
Yes, I'm in Ontario.
I think you're on the right road though. Like you're obviously watching my videos because you
Yeah,
think like, it might be instability, right?
yeah, right. I watch a
Because
lot of
like
videos.
anybody who has chronic muscle tension and it's chronic, like you get like if it was a muscle problem, you could lay down and it's going to go away, or you could put heat on it, it's going to go away, or you could
Right.
take a muscle relaxer and it's going to go away, or you
Yeah,
get a massage and it's going to go away. When it never goes away, it means it's a protective mechanism. You have so much instability that the muscles are clamping down because the your body doesn't want your bones to move so much that it injures your spinal cord, right? Because the spinal cord's in here. So
right.
long story short, there's a thing called the ligament muscular reflex. So when you stretch a ligament too much, there's a reflex that then gets a muscle to tighten. So that's what's happening. So you need to get some kind of scan. So have you had any flexion, extension, or open mouth x-rays?
Yeah, I did.
Okay.
On the Cairo, he said there was some instability in like the C3, C4 kind of region, something
Okay.
like that.
Did he
Um,
refer you to a prolotherapist or to get PRP
um,
injections in there?
he did, but I wouldn't say it's a pro therapy, it's like a pain specialist.
Okay.
Yeah, so he said he can do it with ultrasound.
Okay.
He said I'll need like a what's it called? Um, whatever to help guide the needles better.
Yeah,
Uh,
what I would do is encourage him to do a big area instead of a little area and then to treat the ligaments. Like, in other words, like, as long as he hits all the ligaments and Victor, it's the capsular ligaments. And you know as well as I do, wherever you have clicking, all those areas need to be done. See, the problem is if the doctor just does, if they don't do the area thoroughly, you're going to get some help, but it's likely not going to be curative. And the other
right.
thing too is it heals over like a 4 to 6 week period. So
Oh,
you just got to figure it's probably going to be, whatever 5 visits of prolotherapy or PRP. It's not going to be one visit.
okay, so my question is like, I've seen like the equipment you have, like a CT scan, DMX and things like that. So I have a problem of like diagnosis. So
Yeah.
I really want to get like diagnosis and things like that. Um,
Okay.
so yeah, I'm just not sure who to go to, like here.
Yeah, I just want to show a couple things. Like when somebody looks too much at the cell phone, it's all these ligaments right here. It's called the capsular ligaments. That's what's likely injured in you. And everybody needs to be doing all these things probably to get your neck curve, including you. You got to get your neck curve good. So
Okay,
you have to have your computer up. Don't be looking down at cell phones. This is me on my stomach looking at
right.
my cell phone, but because I'm using my neck muscles, that's okay. This is prism glasses. This is literally what you described. It's me doing prolotherapy under ultrasound. This is an
Mm,
Atlas orthogonal. I'm sorry, this is Julie Hunt, orthospinalogy upper cervical chiropractor. This is
right.
Morgan on her Denerol. That's what I start the night on. I have a Denerol pillow or a pillow with a cutout. So definitely work on your neck curve. And if you don't have access to a digital motion X-ray, obviously I'd prefer you got a motion X-ray. At least have the doctor do all the X-rays that I talked about in this video, like do flexion extension. Then you have to do open mouth because you got to figure out, do I have C1, C2 instability? And if you have C1, C2, the doctor needs to do those areas too.
Okay, so you think ultrasound is good?
No, very good.
Okay.
Yeah, very good. Great. Thank you for letting us talk about your case.
Thanks. Yeah.
Okay. Where do I go next?
We're going to go to Kat.
Is it back or?
Is slide 35.
Oh, okay. So I guess we got to go Karen.
Yeah.
Karen R. I have used prolotherapy C1, C2 successfully to treat fibromyalgia and knee pain. The naturopath I see has tried prolotherapy as described by Caring Medical 4 times, about 2 weeks apart with no success. Okay, that's interesting. So yeah, it'll be interesting, because long story short, there's prolotherapists all over. Obviously, I have a lot of experience for 33 years. It's like surgeons, there's certain surgeries that are routine. Others of them, you got to go to a specialist. A lot of times the natural paths, they're not, a lot of them don't have a lot of experience with C1, C2. So sometimes you have to go to a specialist like the crazy doctor in Florida. Now here, I put this on here just to show that ligamentous cervical instability and a lot of different other disorders, they have common symptoms. So people with migraines and people with ligamentous cervical instability often have blurred vision, brain fog, difficulty concentrating, fatigue, headache, migraines, intense throbbing, pulsing pain, irritability, nausea, vomiting, sensitivity to light and sound, sleep, visual distortions. People with ligamentous cervical instability often have clicking, cracking in the neck with motion. The head feels too heavy for the neck. They kind of feel like they have bobblehead, neck muscular tension, neck pain. Can I ask you a question, Karen?
Yep.
Okay, so long story short, are you going to the same naturopath that treated you successfully in the past, or there was somebody else who treated you?
I've seen 3 different people over the years.
Okay. So the person you're going to now isn't the same person that treated your fibromyalgia and knee pain?
No.
Okay. Can I ask you this? When you got prolotherapy recently, how many shots was it and what solution was it?
Oh, a lot.
Okay. And then was it just normal dextrose prolotherapy? There was PRP or?
Regular prolo with dextrose.
Okay. So let's kind of agree it's likely the doctor was thorough. By your own admission, there was a lot of shots. So sometimes there's another thing going on. Like, in other words, well, let me ask you this. So why in the office? Because, back in the day, I would just do like what that doctor did. I would just do prolotherapy, blah, blah, blah. I wouldn't like do all these tests and we got to test the thing. The reason why I do all the tests now is in around 2007, so about 18 years ago. So 18 years ago, we did a chart review and all of a sudden my success rate for necks, it went down. Like it wasn't, like in other words, instead of like 9 out of 10 being dramatically improved, it was like 50%, let's say. So that took me on the journey that all of a sudden, because of cell phones, the people's neck curves were bad. That's why I started doing digital motion X-ray. So then I thought, well, I'll get the people's neck curves good, and then I'll do prolotherapy. Then we'll get back up to the 90% of dramatic results, And then basically we got it up to like 75%. That's what led to like, well, people have these styloids. They have all these, they have thoracic outlet, they have all these things. So I just decided, let's say 6 years ago or something, when somebody comes, I'm just going to do all the tests and we have all the information. So on the initial visit, I could tell the person, you just need prolotherapy, you don't need to do anything. So I just have a feeling you're probably in that category of there are other things that are well, let's just talk about your symptoms. What's the main symptoms you have, like the top 3 symptoms?
Pain, and pain.
Okay, where's the pain at?
usually starts on the left side of my frontal lobe, moves to the right side, and then down the who's-a-what's-a.
But you understand that could be from intracranial hypertension, like it could be, you could have a left jugular vein block, then you're feeling it in the left frontal lobe. Then as the pressure goes up, it goes to the right. So, you know what I mean? So that's why I just have a feeling there's some other things probably going on, so you might want to have somebody, whether it's with ultrasound or it's with, and always know when they do the ultrasound of the jugulars, you have to have them not just do the jugulars down here, they have to do it way up here too, because the normal compression is way up here. So if your doctor has an ultrasound, they could just do that, or else you have somebody do a CT venogram of your head and neck, and I'm sure you're going to end up having some jugular vein compression likely.
Okay.
Hey,
Got it.
thanks. Thank you.
Doc, there's just a couple questions people.
Oh, are we done with all the?
Yeah.
Okay. Okay, so somebody had a question about achalasia. So achalasia is where the nervous system is getting destroyed in the esophagus. Well, basically that's called Auerbach's plexus. Well, Auerbach's plexus has a connection with the jugular vein, or not jugular vein, it has a connection with the vagus. So normally the way we treat achalasia is we do cervical curve correction, probably about every 4 months or so. We'll recheck the vagus nerves to make sure the vagus nerves are repairing themselves. The whole process normally takes 6 to 8 months. And if there's instability, we treat the instability. Now, most of the time we find that the vagus nerve, like the jugular vein, it's getting too much stretch and compression at the atlas. Somebody has eosinophilic esophagitis, very, very interesting. So the eosinophils are normally the cells that are made with parasites. So obviously the first step is to make sure the person doesn't have any weird parasitic infections. That'd be kind of the first thing. But long story short, I just think when you have vagus nerve issues, and I was the one who coined the term cervical vagopathy or vagus nerve dysfunction or degeneration from problems with the neck. Basically, when you have problems with the neck injuring the vagus nerve, well, all of a sudden you can get leaky bowel, also called leaky gut. You can get leaky lung. Leaky lung can lead to what? Asthma, neurogenic pulmonary edema. It can lead to bronchitis. It can probably exacerbate things like COPD. And obviously you can get leaky esophagus, because the mucosal surfaces, like when you swallow something, you don't want that stuff to leak into the esophagus. Well, let's just say for argument's sake that you have vagus nerve degeneration. All of a sudden, the mucosal cells of the esophagus become leaky. Well, all of a sudden, the esophagus has all these foreign objects in it. You could see where you might get a weird immune reaction like eosinophilic esophagitis. So I think in that case, again, I would check the cross-sectional area by ultrasound of the vagus nerve, and I would look for, is there a breakdown of the cervical curve, then correct it. And normally if you correct it, that condition's going to improve. When somebody has blood pressure swings, like basically there's a couple other cases that here I want to show something. There was a patient that has low blood pressure. So basically, so the blood pressure sensors in the body are in the aorta, they're in the carotid artery, and the two nerves that are involved in blood pressure sensation is the glossopharyngeal nerve and the vagus nerve. They both run in the same sheath, the same container as the internal jugular vein. So you can understand if the blood pressure sensors are off, a person might get high blood pressure, they might get low blood pressure. Now, when people just have low blood pressure in the office, we normally find also that their blood volume is down. So when somebody's blood volume's down, think of this. So you're at the beach and you're getting dehydrated. Then you get more dehydrated. And you get more dehydrated. Guess what happens? You're going to get low blood pressure and you're going to pass out, right? So one of the ways to increase the blood volume is you got to take in a lot more salt. Like I had a patient with low blood pressure and they were getting like dizzy and lightheaded. So I have them intaking every day 4 teaspoons of salt. There's 2,000, I think 225 milligrams of salt in 1 teaspoon. So 4 teaspoons of salt, and increase the water, how much water they're drinking. So I'm having them drink a lot of water and have more salt. Sometimes you got to get tested for, or you have to get on the hormones that help you retain salt. Well, the hormone that helps you retain salt is aldosterone or Florinef. It's called Florinef. Fluorocortisone. It's basically Florinef. So that's one of the hormones that I would prescribe if the blood volume's down in some people. And then vasopressin is anti-diuretic hormone. It's the hormone that helps a person retain water. So sometimes you have to get tested for those hormones and obviously do a treatment that helps the neck get a good neck curve. And if an instability is found, then you have to do prolotherapy to resolve the instability. Wasn't there another symptom? What's the other symptom?
Histamines, intolerant skin and tissue.
Okay, so basically there's lots of different kind of histamine intolerances. Okay, so this is how I look at it. When somebody's tried a low histamine diet, they've changed their diet, they've reduced their stress, and they're still having rashes and various histamine reactions. Again, I look at it as they have leaky organs, if you will. So what happens is when the nerve supply to an organ like the lung, like the digestive tract, the small intestine, what happens is when the nerve supply is compromised, you get basically the mucosal surfaces let things in. Well, when you let things in, you're going to have a histamine reaction. So normally when a person gets their vagus nerves repaired by correcting neck structure, the histamine reactions keep going down, down, down. And we definitely have people that had histamine intolerance, had mast cell activation syndrome. We've had that have been completely better. We also have people that have unbelievable food sensitivities where they could only have 10 foods. Now they can eat all the foods. So basically, I think going the route of the neck often is what's needed to correct body and brain symptoms. Did we get everything?
I think.
Okay, so just love everybody. Appreciate you guys. Hang in there, and Izzy and Michaela and the team here, for those who I need to follow up with, will follow up. But thank you guys so much for your attention. And I always want you to have the best of health. Have a good night.